Hi, everybody. My name is Lisa Herrera here in El Paso, Texas, and I'll be presenting a SOAP note that I completed on a patient during my clinical rotation the week of June 5th. I will present all of my subjective and objective data, my decision-making process and treatment plan, and at the very end, I will explain why I chose to present this patient to you all. NV is a 7-year-old male who presents to the clinic with fever times 2 days, general malaise, a sore throat times 2 days, and now an emerging rash. He is accompanied by his mother, who is the primary historian and is deemed reliable. As far as subjective data and the chief complaint, NV has had a fever and seems to be very tired, according to his mother. He says his throat hurts when he swallows. Now he is starting with a rash to his arms and legs. Regarding the history of the present illness, NV started with fever 2 days ago. He was given Tylenol twice. Mother states that the fever has not gone above 100.7 degrees. NV is now developing a scattered rash to his hands, arms, and legs. And although he continues to drink well, he does complain of throat pain when he swallows. Mom says his activity level has decreased from normal. In the review of systems, his general exam, growth is normal, speech is appropriate, there's no concerns regarding vision or hearing. His nutrition includes a regular diet, however, mother does state that he is not eating his usual amount. He continues to drink fluids well, though. He has an adequate sleep pattern, sleeps approximately 9 hours a night without difficulty. Regarding his skin and lymph system, mother states patient does have a history of eczema, but that there is no recent flare-ups. His last flare-up was about 6 months ago. He originally developed eczema at the age of 3 and just occasionally gets flare-ups. There was no other history of skin conditions, lesions, or birthmarks. There's no complications with the hair or the nails. There's no previous history of adenopathy. The rash appearing on his hands, arms, and legs is occurring just within the last 24 hours. Regarding his head, there's no previous history of any head trauma, no history of complications with head growth and development, and there's no history of headaches. Regarding his eyes, mother denies that there's any visual problems with NV. There's no previous history of eye drainage or pain. With his ears, there's no history of hearing or ear problems. There's no ear drainage, no ear pain. Regarding his nose, there are no complications with the nose, no previous history of congestion or drainage. Regarding his throat, NV does say that his throat hurts a lot and it's very hard to swallow when he eats and drinks now, but there is no previous history of any recurrent throat infections, no swallowing problems. Mother denies any kind of previous problems with his throat. Regarding the respiratory system, mother denies any recurrent respiratory complications or infections. There is no history of asthma. Cardiovascular, mother denies any patient history of palpitations, any murmurs or activity intolerance. There's no other cardiac complications. Regarding gastrointestinal system, NV does not have any history of stomach infections, any recurrent diarrhea, constipation, vomiting, or reflux. Does deny any abdominal pain or any GI structural problems. Genitourinary, mother states that NV does not have any history of recurrent UTIs, no infections, no discharge, no urinary frequency or burning. Mother denies any GU structural problems. Musculoskeletal, there's no history of broken bones, no joint inflammation, no structural abnormalities. He is able to move all extremities equally without complications. Neurological system, mother denies any neurological abnormalities. There's no history of seizures, no tremors, tics, no loss of consciousness episodes, and no headaches. Regarding the endocrine system, mother is unaware of any problems with growth, denies any excessive thirst or intolerance to heat or cold with NV. As far as the hematologic system, she states that there is no history of bleeding disorders, no anemia. Denies any recurrent bleeding or bruising problems. NV has never required a blood transfusion. As far as dentation, mother denies any history of dental trauma. He has a normal teeth pattern and eruption pattern for a 7-year-old. Mother states that NV is very good about brushing and flossing regularly. NV has no known drug allergies and requires no daily medications. The only medication he uses would be Elicon 1% cream, and that's for his occasional flare-ups of eczema. So he takes the 1% cream. He is to apply it to the affected area topically, which is usually patches to his arms, maybe legs. He's supposed to apply it topically once daily as needed for eczema flare-up. She says that the last flare-up was about 6 months ago. He doesn't use it daily, only as needed. Regarding past medical history for NV, NV was born full-term with no complications at Del Sol Medical Hospital in El Paso, Texas. Mother states no previous hospitalizations, no surgeries, and his immunizations are up to date. Regarding NV's family history, mother states that she does have a history of asthma but is well controlled, denies any other medical issues. Father is healthy with no previous health history. NV is the youngest child in a family of 5. He has 2 older brothers, a 12-year-old brother and a 9-year-old brother. Regarding social history, NV lives with his immediate family in a house. They do have a dog as a family pet. NV states that he just completed the 2nd grade and he has lots of friends. Regarding the objective data and my physical exam, general NV appears age appropriate. He is well groomed with good hygiene, and as I'm examining him, there is no apparent distress. NV answers questions appropriately, and his vital signs are as followed. Temperature of 99.9, heart rate is 108, respirations 24, and a blood pressure of 107/70. Regarding his skin is pink and warm, no signs of cyanosis, no jaundice noted. His skin is intact with no bruises, no masses, but there is several small papules noted on the palms of his hands. I do see some on the soles of his bilateral feet. And now we're starting to see little blisters, little papules on bilateral arms and legs. These papules are raised and non-fluid filled. NV does deny any itching with these lesions. Regarding his head, normal cephalic, atraumatic, his hair is short and well distributed around his head. Eyes, extraocular movements are intact. Perla is noted. There is a positive red reflex bilaterally. There's no conjunctival injection, no scleral icterus, no edema, no erythema to the eyelids. There's no drainage noted with his eyes. As far as the ear, nose, and throat, I am able to visualize the tympanic membrane bilaterally. They're shiny and gray with sharp landmarks noted. There is no redness, there is no discharge noted to his ears. There is no nasal congestion, no swelling noted in the mucous membranes of his nose. However, I do see several small papules, vesicles noted across a redness and erythematous base of the soft palate and of his uvula. His trachea is midline, there's no thyromegaly, there's no lymphadenopathy. But what does stick out to me is there's almost a border of vesicles of papules that is noted at the back of his throat, and it's scattered across the border of the soft palate and even on the uvula. Regarding his lungs, I see unlabored respirations, symmetric chest expansion, clear breath sounds. There's no wheezes, there's no rales, no bronchi, no retractions, there's no cough noted. Regarding NV's heart, I do hear a regular rate and rhythm. Normal S1 and S2 sounds are noted. I do not hear any murmurs, no gallops, no revs, and capillary refill is less than 2 seconds times 4 extremities. Regarding his abdomen, normal bowel sounds are noted. His abdomen is soft and non-distended, non-tender to palpation. There's no palpable mass is noted and no hepatosplenomegaly. Regarding his genourinary exam, I noticed normal external male genitalia. He is circumcised. His testes are distended bilaterally, and there's no tenderness or no discharge noted. Regarding NV's musculoskeletal exam, his spine is straight. He's able to move all extremities equally and coordinated. There's no abnormalities noted with his musculoskeletal system. Regarding neuro, he is awake, he's oriented × 3, he has normal reflexes and normal tone, he has 5 out of 5 strength × 4 extremities. No abnormalities noted within the neurological exam. And then regarding lab tests and any other tests that we feel that we need to pursue at this time, there's none required at this time. Regarding moving forward into my assessment, after all our data was collected from a thorough subjective history and physical exam, my preceptor and I decided that NV was to be diagnosed with hand, foot, and mouth disease, which has an ICD code of B08.4, enteroviral vesicular stomatitis with exanthem. The pertinent data supporting this diagnosis is as follows. NV exhibited low-grade fever times 1 day, mom stating that the highest fever was 100.7. General malaise. Several small papules and vesicles noted across an erythematous soft palate and uvula. And then now emerging several small papules noted on the palms of his bilateral hands, on the soles of his bilateral feet, and now on bilateral arms and legs. Oral lesions are typically occur shortly before the hand-foot manifestations, and this was definitely the case with NV. With his low-grade fever, general malaise, and oral lesions and sore throat, they seem to have preceded this new viral rash that has now started on his hands, arms, legs by about a day. So our treatment plan for NV, hand, foot, and mouth disease has unique clinical features and a relatively benign course. Laboratory confirmation of the diagnosis is seldom required or indicated. However, in more complicated cases, causative viruses could be cultured from many different sites, from oral ulcers, from cutaneous vesicles, nasopharyngeal swabs, stool, and even cerebrospinal fluid in cases where meningoencephalitis is suspected. And just for information between us, the most common causative agent of hand, foot, and mouth disease is Coxsackie A16 virus. Other serotypes include Coxsackie viruses A5, A7, A9, A10, A16, B1, and B3. Also enterovirus 71, echoviruses, and other enteroviruses. Most cases of hand, foot, and mouth disease are usually mild and self-limiting. Therefore, the treatment plan is usually geared more towards supportive care and parental reassurance. Supportive care recommendations for NV included the following. We instructed the parents to push fluids NV's appetite for food may be decreased, and this is very normal during a viral illness, but it is very important to keep him drinking fluids to prevent dehydration. Acetaminophen may relieve malaise and minor discomfort associated with the oral lesions in his mouth. It may also be used as an antipyretic in those children with fever. So we told mother to go ahead and she can use Tylenol. Dosage recommended for NV based on his weight of 24.5 kilos or 54 pounds is as follows. To use children's Tylenol with a concentration of 160 milligrams per 5 mLs. He can have a dosage of 10 mLs PO Q4 hours PRN for fever greater than 100.4 or for pain. Another recommendation we said was that mom could use over-the-counter throat analgesic spray, such as chloroseptic spray for kids. This can be used as an oral anesthetic for the lesions in the mouth. Give 1 to 2 sprays to the affected area in the mouth. Let it sit there for about 15 to 20 seconds and then have him spit it out. This can be given up to 3 times a day. We also instructed to mom that after 3 days, the fever should subside and NV should start to feel better. He needs to follow up as needed, but she does need to call the office if he continues with fevers greater than 100.4, if he's not drinking well, if he starts with vomiting, diarrhea, or other symptoms. And of course, she can call the office with any other questions or concerns. Regarding education for NV and his parents, we instructed mom that dietary adjustments often improve oral intake from the painful oral lesions that he has and help to prevent or relieve dehydration. We told her to provide cool or iced liquids in small quantities frequently, things such as slushies, popsicles, ice cream. The coldness will help numb his throat and hopefully help to improve his intake and should have a cooling effect, a numbing effect to help him with the pain. We also told her to avoid spicy and salty foods. This can be very, very irritating to the throat. To avoid foods that contain a lot of citrus, with lemons, orange juice, of course, all the citrus can irritate the lining of the throat again that has the lesions. And in nearly all instances, hand, foot, and mouth disease will resolve within 10 to 14 days after the initial diagnosis and requiring only supportive care. So the lesions inside the mouth will usually resolve after about 7 to 10 days. And then the rash to the hands, feet, the arms, and legs usually will heal within 10 to 14 days. Regarding the reflections that I have on this case, these are my learning points and my takeaways from the specific case. First of all, I wanted to mention that in the pediatric primary care clinic that I am precepting at, it's a private practice. The physicians and the nurse practitioners are very much into simple practices that help to remedy patient symptoms before turning to medication. What does that mean? Simple things that you and I may take for granted. They recommend, using a humidifier at night for congestion or using a hot steam bath to help a patient breathe easier during a coughing spell. Using warm to hot fluids to help ease a cough, things like that. So I've enjoyed relearning these specific practices and recommending them to our patients to try first. But specifically with this case and all cases of pediatric fever, I have learned it is very important to assess the following. Number one, how many days has the patient been having fever? What day is this? Usually, if the illness is viral in origin, the fever will subside after the 3rd day. The problem is that most parents get very anxious and they will not wait 3 days for a high fever to resolve. They'll bring in the child to the clinic with fever less than 1 day or sometimes even less than 24 hours. As a provider, this makes it hard to determine the origin of the fever. We cannot trend the fevers, and if there's no other symptoms, it makes it harder to try to understand what the origin could be. So educating the parents about characteristics of fevers, how long to wait, how to treat at home, and keeping a fever diary is key. A second takeaway I have is always asking now, how is the patient's activity level? Are they still active? Are they still playful? Are they sleeping all day? Are they drinking? Are they still interested in eating? This just gives us a big clue as to how sick the child really is. The next point that I have is there a rash associated with the fever? I have now learned that it's very important to assess all patients presenting with fever for rash, specifically a viral rash. I now make that a part of my overall assessment of a patient presenting with fever. I look at the palms of the hands, I look at the soles of the feet, the extremities, even if that is not mentioned as something the child is developed with fever. I'm looking for clues or possible beginnings of a rash. In this specific case, we at the office actually found more papules and lesions on the feet and extremities that mom wasn't aware of. And finally, I have learned how to differentiate between a viral rash and a rash of some other type of origin. If a rash blanches, this is most likely viral in origin. The correct way to assess a rash, of course, with your clean hands, you will feel it. You're looking to see, is it flat? Is it elevated? Is it rough? Is it dry? Is it smooth? Is it fluid filled? If you press on the lesion and it blanches, it is most likely viral. I also learned that the correct way to assess it, you're going to gently spread the skin around the rash, stretch it out, and if it blanches, this is most likely viral in origin. If the color or the redness remains, you're probably dealing with some other type of origin of rash. Finally, this was a pretty basic viral illness, but it was interesting to me because I actually got to see the beginnings of the hand, foot, and mouth disease, to see how it progressed in stages and to recognize the textbook presentation of the oral lesions and the skin rash. I work in a general pediatric unit, and by the time I usually see these kids, they are just very dehydrated, requiring fluids. So it was pretty neat to see the beginnings of the rash, to see the oral lesions, how that presented, and then of course the rash starting to emerge. I was glad to share all this with you. I hope that you got something out of this, and I wish you all well. Thank you.